Yeah, thanks, Christian. And of course, it wouldn't be a conference of these times if there was not a discussion about the impact of COVID. And as you all already started, Nicholas Waters. So in this panel discussion, we welcome Professor Ulrich Hegerl and Dr. Arlinda Cerga Pashoja to discuss exactly this topic. So Ulrich Hegerl is a highly sought after expert in suicide prevention. He has developed a community-based intervention for a better care of depression and prevention of suicidal behavior, which has been implemented in Europe and Chile and Australia. His main areas of research include treatment of depression, public mental health, and community-based mental health interventions, suicide prevention, neurobiology of psychiatric disorders, functional brain imaging, and sleep-wake regulations, and he has more than 500 publications in peer-reviewed journals. He's president of the European Alliance Against Depression, who is also a partner in this project, and he was recently assigned the distinguished professorship funded by Dr. Senckenbergische Stiftung at the Department of Psychiatry, Psychosomatic Medicine, and Psychotherapy at the University Hospital in Frankfurt. Arlinda Cerga Pashoja is Assistant Professor of Global Mental Health with the London School of Hygiene and Tropical Medicine. Her research interests lie in the development and evaluation and implementation of culturally appropriate digital mental health interventions in low-resourced settings, with a focus on countries of Central and Eastern Europe. So I'll moderate this panel, but I really invite you to any questions from you in the audience, and you can type them via the Q&A function at the bottom of your screen. So welcome to Ulrich and Arlinda.
Good morning, all.
So first of all, just to start you off here, maybe could you elaborate on for us if you have seen any change in the perception of e-health intervention, or maybe the uptake of e-health interventions caused by this pandemic?
Arlinda, please.
So I'll be referring to the countries we've been working on ImpleMentAll. So I'll be referring to Albania and Kosovo, who are part of the Balkans, Southeastern Europe, where, as Kim was mentioning, they're not in the well-developed side of the countries of the rest of Europe in terms of mental health provisions, but also digital uptake. Nevertheless, throughout the COVID period, with the pandemic breakout, there's been a shift, as it's been everywhere, I assume, and that's also been mirrored in those countries too, with all the different challenges they've been going through, with considering the high stigma for seeking help for mental health. That seems to be shifting because there's been a more open talk about anxieties, about getting unwell, how others getting unwell, losing jobs, and all those. The people started talking more openly about those, and then associated feelings that are quite normal. So there was a kind of a normalization process. We're kind of seeing a change and a shift in the help-seeking behaviors of the population, and also digital mental health for us. That's kind of came in there quite naturally. Some governments have included it in their COVID response. For example, Kosovo does. Albania has not mental health is not part of it. But that's kind of the differences within the region and within the different perspectives, I think.
Yeah, so I can speak a little bit about the experiences. Is there echo? Is the audio okay? Or is there echo somewhere? Okay. So we are using the I-Fi depression tool, which is a CBD-based e-mental health tool for people with mild to moderate depression. And we had the experience that during the lockdown, there was a huge increase in uptake it's normally a guided tool. So we need a health professional who offers the access to the tool to the patients. But at the lockdown, patients were afraid to seek help. And therefore, we opened it so it was available without guidance. People could go directly to the page and use it. And within very few weeks, about 15,000 people used this tool. And we also saw that the number of guides, these are people who are working through an e-learning tool in order to provide the alpha depression tool to patients, that this also went up. So there was a very clear increase in use of e-mental health tools. In Germany, in 2020, there was also a big change in legislation. I think Germany is one of the few countries where you can now prescribe e-mental health tools. So the health insurances and the physicians and the psychological psychotherapists can prescribe as drugs e-mental health tools to patients. There's a list, a certain procedure to get on the list, and when you are on the list, you can be prescribed. So this is something I would say experimental, and of course something which influenced very strongly the acceptance and the uptake of e-mental health tools. We also made surveys on the acceptance of e-mental health tools of concerning depression, and we made a representative survey which involved also about 2,000 patients saying that they had a diagnosed depression or that they believe they have a depression. And here it is very, very clear that in the last years, we did several surveys over the years. Compared to 2017, there was a much bigger readiness now to accept it, especially the concerns concerning privacy. We are going down very strongly. Also, the number of people who feel that it might even be detrimental to make psychotherapy with the support of e-mental health tools, the number also went clearly down. And even comparing the survey from June, July 2020 to the more recent survey in February of this year, there was also an increase in the acceptance of such tools. So it's very clear, and the number shows it also, that the COVID-19 has boosted the uptake and acceptance of e-mental health tools. And I think this is not but everywhere.
Yeah, so this is on several levels. If we go back to the micro, meso, macro distinction between implementation efforts, then legislation is a very broad context, of course, and then all the way down to how the patient pathway is really formed in Germany. So all of these levels seems to have been affected, yeah, in Germany.
Yeah. For example, people saying unpersonal. In 2017, it was 79. Now it's still quite high. 72 people are saying they perceive such online self-management tools as too unpersonal. But concerning privacy issues, in 2017, there were 70% who had concerns, and it went down to 55 in 2020 and now to 48 in 2021. This is a very sharp drop in concerns. I think there are good reasons to have concerns concerning privacy issues, but the people have a different attitude now, and also that it can be detrimental went down from 47% who were afraid it can be detrimental in 2017 to now 31%. So huge changes in the acceptance.
I think it's really important also to talk about the challenges for these countries who not in the higher income list with low resources, as we mentioned. One of the difficulties that we faced with EMA it's been, or one of the challenges for us, it's been to address that digital divide or the inequality in the access to connectivity and digital means of accessing e-mental health. And that's been an ongoing issue. So we had to fund or to invest quite a lot in the community mental health centers that were working with us on this. However, with COVID times, what happened was that those community centers kind of shut down or shut their doors to people, especially people with not severe mental health problems who didn't need medication. And that affected our group of clients. So people with depression and anxieties were kind of excluded in a way. And it's quite similarly what happened and what's happening with the rest of the world, where people did not access mental health services, either because they were afraid because of contamination or getting transmissions, or because there were difficulty in accessing them, and everyone was working from home. Therapists were working from home. So in that sense, all the investment that we had made in terms of providing computers and connectivity in the centers, we kind of lost that. So the therapists now moved working from home, but they did not have, many of those people that were working for IMA did not have access to either internet or the specific PCs that they needed. And that was the same with the clients. Those clients that could still access were those that had the connectivity. So the disbalance, and that was quite a worry that we couldn't do anything about, unfortunately.
Arlinda, may I ask, the uptake of telephone counseling has a lot increased in Germany during the lockdown. What is your role in Kosovo and Albania concerning telephone counseling?
Well, counseling and psychology interventions are not a usual thing. They're quite new. People from our work that we're doing with IMA, what we realize is that the centers for community centers for mental health are quite new. We're coming from a background of hospitalization and institutionalization, so it's quite new. And the psychology as a profession is quite new in the countries. So there is a lot of suspicion and distrust, not just from the public, but also from psychiatrists to psychologists and GPs to psychologists. So the context is quite complex. It's not similar to Europe's context. So those issues now, GPs are working online, psychiatrists are doing telephone consultation, but psychologists, I mean, we open, as Ulrich mentioned, we opened the I-5 depression tool to everyone in Albania and Kosovo during the first peak of the pandemic. And the uptake, if you compare Germany with Albania and Kosovo, it's detrimentally different. We only had just a handful of people requiring access, when in Germany it was quite different. And we were invited into TV news and shows, so we were quite visible out there, but still the uptake was really low. And it tells you a lot about the health-seeking behavior and this stigma, the high stigma about accessing treatments.
So for you, Ulrich, we just got a question in from the audience from Kari, who asks, do you have any thoughts on the role and potentials of technology to provide suicide in prevention to persons without therapy access?
I think you can, of course, provide information and help people to get at the right place. But I think this is a shortcoming of the e-mental health tools, CBT-based tools, for example, which might be as good as face-to-face psychotherapy in reducing depression, but I'm quite sure it's not as good in detecting people who are in acute crisis and might have suicidal thoughts. They are not ready to communicate. So I think it's tricky. I don't think this is the right way for suicide prevention. It's if you try to make a campaign or to use social media or other channels to make something like a public campaign, it always has two sides. It might improve knowledge, help seeking behavior, might reduce stigma. On the other side, it might lower the threshold for suicidal acts. And I personally know many, not only one, but many patients who are only still alive because of the taboo and the stigma, because they say, I'm a burden for my family, for the society, for everybody, I'm a burden, it would be better not to be here. But they didn't want to blame their family because of the stigma. And if you normalize suicidal behavior by using mental health tools, and you lower the threshold, and the number of completed suicides might go up. This is what you observe, for example, I think in the Netherlands. I do not know exactly how it's discussed there, but they have not only every year about 6,000 people who are killed by physicians, but also an increase in the non-supervised suicide, in the normal suicide we see in all countries. So this might be a result of this normalization process. So it's a very tricky point, and I do not see a good approach using mental health tools in this area, in addition to providing information where to seek help.
Yeah, so really the main obstacle there would be how to promote these services rather than the service itself. Is that,
yes? I think to provide information that if someone has suicidal thoughts, where to seek help, that it's very often the context of psychiatric disorders which can be treated. This kind of information, of course, you have to put out. And that if someone commits suicide, it's in nearly all cases not an act of free will, but a very sad outcome of an illness which has apparently not been treated well. I think this information you have to put out. Problem also is if you make too much public relation activities concerning suicide, you cannot control secondary reporting. There might be chat groups which pop up and suicide pages might grow. There are a lot of these pages around. And so you cannot control secondary PR effects, even if you give very good information. The secondary effects are hard to control. So I have not a clear opinion what is the cost benefit or the advantages and disadvantages of supporting PR and mental health tool targeting suicide prevention. I'm a little bit reluctant.
Yeah, and we've seen that increase also with self-injury, for example, self-harm in self-help groups, and if they're unsupervised. So, but on the other hand, I've heard people advocate this along the lines of if you can make a service that's anonymous, it'll appeal to someone to seek help who would normally not seek help and then would be at higher risk. Is that something you would recognize?
Yeah, of course. This, for example, I think it's a 113 phone number which has been developed in the Netherlands. Probably it's a very good idea if there is a well-known number. If someone in acute crisis can speak with someone who knows how to deal with these therapy situations, I suppose this is a very good idea and very helpful. This is telephone counseling.
Yeah, and telephone is tele as well, right? Yeah. So I think we need to be careful not to just only look at like online programs or something. So anything on a distance using technology is kind of within this field, I suppose. So all right, thanks, Kai. That was a very interesting question. We also have a couple of other questions from the audience. Erik, for example, whom we heard from yesterday, ending with a keynote closing the day yesterday. He writes, curious to hear from Arlinda about privacy issues in the Central EU countries. What about legislation and change and restrictions on mental health interventions due to privacy regulations? Independent, he says, of the email project.
That's a very good question, Eric. Unfortunately, I think the problem with the legislation is that it's not being implemented. So whatever is in the legislation, it's great on paper. Mental health is not mentioned there. The Mental Health Act came very late, was introduced very late in Albania. So that's quite recent, and it was more worked like a forced exercise rather than a normal or required to join the European Union, rather than an organic development. Unfortunately, it's not being implemented. Most of the elements of the Mental Health Act are not being implemented. There's no specific relationships between, the different parts of the act, of the Mental Health Act, with the privacy laws. So that's, at the moment, there is privacy concerns from what we've heard from clients, especially around treatments and psychological treatments. But it's not regulated at the moment. It's not implemented at the moment.
All right. So we also have a question from Duyong, who asks, e-health interventions require access to technology, but there's often a big gap. Are there currently any works being done on bridging this digital divide in terms of implementing e-health interventions?
I didn't understand the question, excuse me.
Okay, I'll read it again. So I'm sorry. E-health interventions require access to technology, but there's often a big gap. Are there currently any works being done on bridging this digital divide in terms of implementing e-health interventions? So I think this is really...
Arlinda. Mm-hmm.
Yeah, and also I think because we often talk about the equality of access to health. And we want everybody to have equal access to health systems and e-health systems. And this is e-mental health is often promoted as a way of making this access more equal or more democratic, you could almost say, in a way. But there's also the digital divide. That's maybe a new form of inequality.
Yeah. Absolutely. And as I said from the beginning, that's been one of our challenges with difficulty in access. And the difficulty can be at very different levels. That's what we realized during this study. So, for example, to get access to a tool like the ItFit toolkit that we're using with European Alliance Against Depression, you need an email address. It's very simple. So we had lots of clients who are using all kinds of social media, TikTok, Instagram, what have you, but don't have emails. So that was very interesting to find out. So that didn't allow them to basically gain access. And when we kind of helped them, try to help them to set up an email address, which is quite easy, they were not interested in it. So it's probably also a way of different, cultures and parts of, so that there's that level of detail that can be a challenge. However, on the other hand, I think it's kind of been quite helpful, the using the digital support in lowering the stigma, as people wanted to remain anonymous at some points. And our strategy or our theory was, even if we can reach 5 more people, that we wouldn't have been able to reach through the traditional ways, that's still an achievement. So we kind of try to use that technology accessibility in our advantage. In terms of lowering that divide, I think that's something that needs different, politicians, and takes legislation and infrastructure. So it's beyond, I think, our means to close that divide. But using mobile phones sometimes has helped. So people don't need to have a computer. They can access apps on different mobile settings, and lots more people have mobiles than computers and laptops. So that's been one way of dealing with it, and telephone contacts as well.
Interesting
I think I would see it more as an option, more you have available, not I would not see the negative aspects. Not everybody likes it. It's not. Some people say it's not for me. I want to see face to face with someone when I speak about these very personal things, and others like it, and it's an option more and not an alternative, and not an. It will not replace normal psychotherapy and pharmacotherapy, but it's an option more. So I see it in a positive manner, even if this option is not available for everybody.
Yeah, interesting that email is now getting old-fashioned. I wouldn't have guessed. Anyhow, so I have a few more questions here. I think we'll just grab one of these. So Robin, for example, asks, how do you see e-mental health being used after the pandemic? During the pandemic, there was or is an increase in e-mental health problems. However, in Norway, we noticed that when restrictions were lifted, people got back immediately to face-to-face treatment, not using e-mental health. So the question was, how do you see e-mental health solutions used after the pandemic?
In our survey, we asked people what were their experiences with video counseling, also with using other e-mental health tools. And about 80% were saying, I made good experience. And this was higher, I suppose, than they had expected in advance. So there will be many people who have made positive experiences. And also the psychotherapists in Germany, I speak about Germany now, the psychotherapists learned how to use it. They have now the tools available. They have made experiences. And if they have already an established relationship with a patient, that this can really be helpful. But I'm quite sure that this will have long-lasting supporting effects concerning the uptake of e-mental health tools.
I agree. I think the blended way, blending face-to-face with online, and what Nicolas was talking earlier, is probably the future for the moment, after COVID.
All right, excellent. And by the way, Robin, who just asked this question, will be leading one of the workshops later today about the usage of ItFits toolkit in a very large scale project in Norway as well. So so you can hear more from her and her discussion points later on. Anyhow, I'm afraid we are running out of time on this very interesting topic. So I'd like to thank both of you, Arlinda and Ulrich, very much for the discussion here and the debate.